I have a question for you. So I'll start and then I'll turn it over to Amy, who can be our mediator up here. I often have patients tell me that they are carrying around e-cylinders that are rolling around in the trunk of their car, which gives me cause for concern. And I had someone ask me, it says in my instructions not to place in a heated place. How hot can they be? And do you have guidelines? And how do you suggest our patients carry all the extra Etanks that they need because of their high flow? What is the safest way?
So somewhere that's secure, for sure. You don't want them rolling around and bouncing against your trunk walls and different things. Here in San Antonio, it gets pretty hot. I don't know if there's a certain degree. We'd probably have to look into the manufacturer manual on what they recommend. As a rep and as my timely service that I try to provide, I'm always called into hospitals to make sure patients can discharge with home oxygen. I keep about 4 E-tanks in my trunk at all times, and it gets about 120 degrees here, so no problem so far.
So we do have Ephraim's out there in the audience with a mic. We have 2 for questions.
Hi, the question I've got is that oximeter cannula. That's kind of the first I've heard of it. Is that provided if you ask your DME, your oxygen company, can I have one of those? They just, you pay for it, or they just have you pick one up?
It should be a written prescription from your doctor.
Okay.
Patient to use oxygen via oximeter nasal cannula, and there shouldn't be any issue in obtaining it.
Thanks.
Hi, I just recently got a POC from Philips, and I can't tell if it's working for me on a pulse. So one question is, can I determine that at home, or got to go someplace else to get that resolved? The second thing is the unit itself pulses every 5 to 10 seconds. But does that do me any good if I've got the cannula in my nostrils?
So
do you understand my questions?
It's pulsing without you triggering the inspiration?
It pulses every 5 to 10 seconds, yes.
Yeah, I would probably talk to your manufacturer and see if there's an exchange that can happen. It should be based off of your inspirations. Every 5 to 10 seconds could be a kind of a backup in case it didn't trigger, just to make sure it is triggering every 5 to 10 seconds. But that's probably a manufacturer question. I'm sure it's in the...
I think the instructions said it's supposed to do that.
Okay.
So, okay, so let's go to the first question then. How can I determine myself that I'm actually getting a pulse? I have a pulse oximeter, I can check that, but is that adequate?
I mean, in general, yes. If you are using your POC on pulse and you're walking, and you have an oximeter that you've used and know how to use it, that should be adequate to make sure if your saturations are staying above 90%. We often have patients bring their oximeters to clinic, and we'll often do a little controlled trial. I'll have ours on the finger, and they'll use theirs just to reassure the patient that theirs is consistent with ours. But yes, if you have an oximeter and you're adequately staying above 90% with your exercise and with the POC, and most patients can sense it triggering, yes, I would say that's adequate. But again, take it with you every time you see your physician or clinicians.
Well, I'm not so much concerned about the pulse oximeter being accurate. I'm a little unsure that I could check my own the efficacy of the pulse. So could I get my pulmonologist to do to check me out on the machine and see if I'm getting adequate pulses?
Yes, I would say yes. And sometimes they have a medical assistant that are trained to do this in their office, or a nurse. But yes, you could ask them that they would like to have it checked. And I would also just put a plug in again for pulmonary rehabilitation. That's another option where you could really have a more lengthy education and training and really know how to use your oximeter and confirm that you're using it correctly and getting good readings.
Okay, it'd be very difficult using the oximeter again.
I was going to add to that. I think the other thing that we tell people in our clinic, or I tell people in my clinic, is that you can learn how to check that pulse oximeter with the activity in the office, but it doesn't always mimic the activities in your daily life. And so it is important to sort of learn what your providers there are doing in the clinic, and then do some spot checks in your daily activities. I tell people not to glue their oximeters to their fingers, but if you can spot check during certain activities and then sort of know what your needs are, whether you need your oxygen in that time or not, and how much during those particular things that you're doing, and then sort of move on, and if something changes from that baseline, then you know to alert your physician. We have another question.
Yes, hi, my name is Judith. I'm a respiratory therapist. I think this is for Susan. Oftentimes, we will do a 6-minute walk test in the clinic, and the patient might need 2 liters of oxygen when they're walking. They'll go to pulmonary rehab, they'll be put on a treadmill, and now they need 6 liters on the treadmill. So my respiratory therapist at pulmonary rehab will call me and say, this patient needs 6 liters. I don't believe that that's a qualifying test, but maybe it is. So I just wanted to know how you deal with that.
Yeah, that's a good question. So I think that well, there's one comment I'll make, and then I'll let others answer. You know, when we do a 6-minute walk, or now that that's one level of activity, and at rehab, it's a very high level of activity. So sometimes the patients, you know, they may not be doing that same level of activity at home. So that therapist is correct that on that treadmill during that training, they might need 6, but I would probably say that at home they're not reaching that level. But I also agree with you that that's, unless that physician is the medical director and the patient's physician, that probably doesn't qualify because it's not a face-to-face. But if you can send that data in to the clinician, then they review it and they could write a note, that would help. But I must say I don't know the answer. Maybe you can, yeah.
I think there's a lot of levels to that. Number one is if you're committing your patient because you're trying to meet their pulmonary rehab needs to a much bulkier or less usable device, that's something you want to certainly take caution with. I think taking a step back from that, the pulmonary rehabs differ in what they are able to offer their patients sometimes in terms of supplemental oxygen. In our system in particular, those that are primary pulmonary rehabs will have supplemental oxygen supplies either through the wall or large tanks that they'll allow the high flow oxygen users to use during their rehab activities, and they can go back to using their concentrators or Etanks or whatever it is that they're using in their daily life, and know that those activity levels are usually generally different. On the other hand, there are some pulmonary rehabs out there that don't have the ability to offer oxygen to the patients and the supplies that they need. And so they may, in some ways, need that patient to have more oxygen or limit their pulmonary rehab activities. Modify them in some ways, so maybe they're not doing a treadmill, but the arm bike kind of deal, something like that, and maybe that's a conversation to have with the pulmonary rehab. In our system, we do 6-minute walks at the beginning of rehab and at the end, and our rehab folks alert me if it's on that 6-minute walk test on flat ground, not so much that their exercise oxygenation is distinctly out of proportion, but that their baseline walks before and after are different. Does that help?
Yeah, I've got a couple of questions based on portable concentrators. The first is, if you look at oxygen saturation of 21% here at sea level, now you're in a plane and say 17%, do the portable concentrators, are they as effective and as efficient at this altitude as they would be at altitude of an airplane at 8,000 feet?
Yeah, we can all weigh in on this. So it's you do raise a point. So so you may need a higher setting, first of all, because if you're using 2 liters at sea level, and you would work with your pulmonologist, you may in fact need to set that POC at a higher rate during flight. Okay. So that you're correct. 2 at sea level will not be the same saturation as 2 at 8,000 feet. And again, we'd ask you to check your sats while you're on the airplane.
Okay.
And any other? Yeah, yeah.
And the other question regarding the portable concentrators is, what if your oxygen level is fine here and during your 6-minute walk test and your day-to-day functions? It may fluctuate in the low 90s or maybe even in the upper 80s. But then when you get into this test, and they say, well, at altitude, your oxygen levels really drop down into the 80s to where you need some help at higher altitudes or maybe on a plane. Is it possible to get a prescription for only to use oxygen concentrators when you're in such environments? Like if you want to go on vacation to Colorado from here and you have that problem, how does that work?
That's a little trickier, right? So I don't want to advocate for being sneaky, but don't. But there are, maybe some things that when you're doing that 6-minute walk test on the ground, your therapist or physician might have you do a bit more than you would otherwise do with sort of an ATS standard walk to sort of prompt your oxygen levels to go a bit lower to justify that prescription. What I have done in the past really depends on the frequency that the patient is seeing that altitude. So if they are flying very frequently for work or for pleasure, whatever it is, then they might end up getting a POC out of pocket, and just because they can't get it reimbursed in any other way. The other option is to potentially just rent, if it's an infrequent activity, just to rent for the specific activity that you're planning at that point. That's where I would reference back to my sort of tricky comment there, and work with your provider about some ways to sort of provoke. If you drop a little bit, provoking a little bit more with more exertion, sort of as she was referring to, with more exercise or a more vigorous activity.
I'll weigh in on that a little bit. So in our experience here, at least locally, there are companies or small mom and pops that will rent private pay. So if you're going for a weekend or a month or 2 weeks, they'll say it's going to be X amount of dollars. They will have to have a prescription, but you don't necessarily have to qualify Medicare standard guidelines with your oxygen saturation testing. So as long as there's a prescription that the patient requires oxygen during travel and at altitude, then all the face-to-face and testing and stuff is not required because Medicare is not paying for it.
So that's a good point. If you're going to pay for something out of pocket, your doctor can write whatever they want. It doesn't really matter, but it won't be reimbursed. That's sort of the issue with not being able to document those low oxygen levels.
The other trick we do is stairs. I've been having to follow a patient as fast as I could upstairs just to try and get them to desaturate. So that's the other way of increasing the intensity.
Treadmill with an incline.
Yeah, I don't have access to a treadmill, but yes, anything, yeah.
Hello, I have 2 questions. First one I think is pretty simple. When wearing a POC and a nasal cannula and it's on pulse dose, should you have your mouth open or closed when you're breathing?
Mouth open or closed with pulse dose.
I mean, all cannulas are in a nose, so they're based on nasal trigger, and they'll sense a trigger. I mean, but yes, it's based on, and I can let the tech, but that's how they trigger is through. Now, some patients I've seen put a cannula in their mouth. If they're really a mouth breather, I don't want to comment on that, but through the nose, so you should be breathing through your nose. But everybody opens their mouth to breathe when you're exerting yourself, but it should still trigger.
Okay.
Yeah.
Then the second one, can you explain what the proper protocol is for a 6-minute walk? 'Cause I've done some on room air, and with my oxygen sat dropping, they stop the walk. And I've done other ones where I've started on oxygen and I'm allowed to continue it. So I just want to know what the right protocol is.
Yes.
What ATS says you should do. So from a physician's perspective, the way that we do a 6-minute walk test sometimes differs depending on what it is that we're trying to accomplish. And so there are ATS guidelines, which I think Susan can speak very, very well to, but I might vary from those if I am attempting to justify the use of oxygen in a patient versus if I'm just trying to look for markers of disease progression, and then you want sort of an apples-to-apples comparison, but we might change things up if we're really trying to provoke something to justify a change.
So that's just a follow-on to that. So there is a very standard protocol, first of all, and that's it's published, and there is standardized distance. There's standardized instructions. You know, the object of the test is to walk as far as distance as you can without running. So they should be reading this. It should be the same coaching every time to every patient, and there's the same phrases. You've walked 1 minute. You've got 5 to go. The same coaching phrases. Good work. And we also document whether the patient's pulling their own equipment, carrying their own equipment. What we don't want to hear is faster, faster, you're doing great, you know, slow down, or walking with their friend and chatting during the walk. So those, we want it as controlled, as systematic as possible and following a protocol. So the second is, she's correct, we order it for different reasons. So sometimes we'll do the walk and we'll look in the record and see that it was done on room air, and we might want to do it again on room air. So we're comparing apples to apples. And then if the patient desaturates in our institution, we then switch to what we call exercise oximetry or oxygen titration. Then it's a different test. We're just walking you to figure out how much oxygen you need. But you're correct, when you come back for testing, maybe now you've been using it at 2 liters. And it's hard as a clinician to look at your last walk was done on room air, and we get the result at 6 months and you've been on some therapy, and now we see your 6-minute walk and they did it on 2 liters. It's a little harder. So it's actually a nice conversation as a patient if you can say, you know, last time I did my walk on room air, do you want me to do it again on room air? Sometimes when we put the orders in, we will say, please do walk on room air, or because we really want to keep it the same, or we might say on 2 liters. And it varies for the goal of the walk. So the 6-minute walk is a very standardized protocol, and it can be done on oxygen or off. Oxygen titration is just when we're walking you in the hall to see how much you need. We're not measuring distance. We're just seeing, is 2 liters enough? If not, we stop, rest, try 4 liters, walk you again. That's titrating to get your oxygen prescription. I hope that answers it.
I'll add a little to that. I don't want to hold up the questions, but for qualifying purposes for Medicare guidelines, if you have now jumped over the threshold from 4 to 5 liters per minute, you get put into a new category. So to qualify for home oxygen at 5 liters per minute, whatever, if it's at rest or with ambulation or anything, you have to prove that you're desaturating with ambulation on 4, just to justify that you actually need 5. So that could be another thing where they walk you on room air, walk you on 2 liters, walk you on 4 liters, and then walk you on 5, just to justify your need for high flow.
So if I could, I'd like to go back to the comment from the RT over here where there was a patient who needed 6 liters while on a treadmill and needed only 2 liters during the 6-minute walk test. And this is less of a question than more of a comment and observation on my part, but I would welcome any further comments on this. So from my experience as a longtime support group leader, I think this is a very common situation where we see patients who qualify for oxygen based on their 6-minute walk tests, but they are still able, capable, and want to do more vigorous outdoor exercises where those requirements go up, and they go up considerably. But because of the levels that they've qualified at, they really don't have the right amount of oxygen or the right equipment to allow them to pursue these other activities that they would normally be able to do if they had normal lungs. In a sense, that almost borders on discrimination against those types of patients because they can't get what they need. So I would welcome any comments to that observation.
So I fully get that. And I think the first thing you might try is to have, if the patient is really being held back for, like you say, hiking and their activities, and we do see some of this, I would have the patient come back and I would run them up and down stairs. So if they have the comment that, you know, my pulmonary rehab testing at this high intensity of exercise, I need to replicate, so I have a physician. And you could ask your physician to do that. And that's one option that we've done, because we realize That's a very good point you bring up. So we have tried to do that and mimic a higher intensity just to get that sat and get higher amounts of equipment.
So to that point, Susan, would Medicare accept that though for additional oxygen?
Yes, we document in the note in the medical record, patient exercised 4 flights of stairs, saturate 84%, oxygen applied, yes.
Okay.
We do a stair, I forget how we word it, but we would word it so it was higher intensity. But,
All right, good, thank you.
We say 6-minute walk a lot, but a lot of times what we mean is exercise oximetry. It doesn't necessarily, Medicare, commercial insurance do not require that you have a formal 6-minute walk test to qualify for oxygen. It's really a demonstration of hypoxemia, either at rest or with exertion, and the level of that in correction with the addition of supplemental oxygen that you're looking for. If you can document that, then I think that's achievable.
And if you're established or the patient's established on oxygen already, say at 2 liters a minute, they're having higher levels of activity than they were doing during the 6-minute walk. Again, checking your sats during that activity, seeing that they're not adequate. For a DME company, as long as that patient's established on services with us already, we don't need a new face-to-face. So the doctor, as long as it's not high flow, if it's 4 liters or less, they can write a new prescription for 4 liters and see if that's more so maintaining the sats where they need to be with the increased activity levels without having to go through a whole new one and maybe titrate them the next time they come in.
Hi, my name is Doug Jones. 2 questions, if I may. One is an equipment question. I use oxygen when I sleep. I have a CPAP machine. As I understand it, I'm supposed to have a continuous flow oxygen concentrator or oxygen with that. I had challenges traveling with that. I finally found a machine, Simply Go by, I think, Philips Respironics or something, which weighs about 10 pounds, but the maximum continuous flow on that is 2 liters per minute. So I was wondering if there are other really portable oxygen concentrators that you can take with you. I mean, I brought it on this trip with me. I took it around Europe as well, so it works for me, but it's much more cumbersome. It will fit under the seat, but are there better options now available?
So depending on your provider and their service areas, for Apria, if you're going somewhere, and it kind of depends on your modality of travel too. If you're flying, then we'll offer you one of those portable concentrators that are continuous and pulse dose for travel only. But if you're going to be staying a little while in a specific spot that, say, Apria actually services that location, we're more than happy to provide you with a home concentrator in your hotel room or wherever you'll be staying so you can maintain your sats during night and bleed into your CPAP and everything.
Okay, so I can explore that with my supplier. Second question relates to one that's been mentioned before, which is the Medicare payment and the contract. I just recently became aware of this 5-year deal that goes on, and I noticed that it's explained actually fairly well in the Oxygen Basics book from the Pulmonary Foundation. But I wonder if you could speak to that, because when I first got my oxygen, both for a home concentrator and my POC, an Energen 3, I didn't have any choice. I mean, they just called and made the arrangements and it got delivered to me. But I now understand from talking to other people in my support group that changing that is a major problem, if not impossible. So I wonder if you could speak to that. And I'm also at the 5-year end of my thing, so I want to know if I have some options as I go forward.
I'll speak to one part and let the others. I do know that if you are into your contract, and then there is a 5-year contract, and if you're in more than 6 months, it is very difficult to change. I would say that we just successfully did this with a Medicare appeal because the DME was no longer able to meet that patient's high flow needs. So we had to file the appeal, which is a 3-way phone call with the beneficiary and ourselves and the DME. This is not, they do not make it easy. But we were successful, and now that DME, that patient can change DMEs and have a new contract. So there is that part that if the DME can no longer meet your needs and you're well into your contract, you can file a Medicare appeal, and once it's filed, then they can change. I'll let, you want to comment? But it is a 5-year, but you're at the end of your 5-year contract? Okay. Then he can change.
Yeah, you should be eligible for a new service. You will have to, though, go through the whole process again, the 6-minute walk, prescription, the face-to-face, and everything to requalify. Apria's policy, like she said, is 6 months. The reason being is the reimbursement's for 36 months of that 60. So, say Lincare is another company you're aware of. So you're on service for Lincare for a year, and you'd like to transition to our services. We're going to provide you our services for 4 years, but only be paid for 2. So it just doesn't justify it for us. We need to make sure we have at least 2.5 years of that 5 to make it profitable, or at least break even, to make sure we're giving you the service that you need. And it's unfortunate, but it's kind of how it is.
I think we have time for one more question.
Okay, I have 2 questions.
Maybe make it one question with 2 parts.
Okay, fine. Okay, I work out a lot, and I have both an Integen 3 and a Philips. Okay, and I run them on max when I work out, because I run a lot. And they had said to me that I should run my units initially at 5 or at max, so that, because once my oxygen drops, it won't come back up. You'll go on the treadmill for 27 minutes. So if it drops down, it doesn't come back. And I want to know, how true are the readings at 5? Could these units maintain 5, max, the portable units, the pulse units? Do they maintain the same oxygen flow for the, at that level? Because someone had said that they don't.
I think that, so these are portable concentrators, you said, an Integen and Philips?
I have the Integen and I have Philips. I have 2 of them.
Okay.
And I use both of them, and I run them both at max, because in order for me to keep my running on the treadmill, I drop, my oxygen level drops if it's not running on max. But I want to know, how true do they stay at 5, at the maximum level, these units? Do they able to maintain it? If you run them for 27 minutes, for example, at 5, the batteries usually burn out at that point. Yeah,
so anytime you run a piece of equipment harder, the battery life is going to be lessened.
I'm referring to the oxygen level. I'm not.
Okay.
The battery I know dies.
Okay, the oxygen level you're referring to is the pulse dose level. So
Yes.
the pulse dose level is going to be 5, but like we have said, that doesn't correlate to liters per minute. So
I understand that.
and a 5 on your Respironics may not be the 5 on your Integen. So they're just so different. And if it says it's a setting of 5, no one can really dispute that, other than it sounds like it's performing higher than it was at 4. A setting of 5 is just a setting, so there's no
number.
Right. It's just a number, so it's kind of hard to tell how hard it's working.
But I just want to know, does it go down? Is the unit able to maintain it at 5? Say it's at max.
It should,
Yeah.
until the battery dies.
Yes.
Until the
It
battery
should
dies.
do the same thing until the battery's dead.
Okay, that's
And
what
then
I
it
wanted.
would
I thought
stop.
Okay, so that will
Yes.
hold through the filters, because it's going through filters. That's why I thought.
Yeah.
Okay, the other thing is, on a 6-minute walk, okay, basically, like I work out, so I'm able to do a 6-minute walk without oxygen at a very fast pace. So I'm able to really regulate my 6-minute walk either way. I could either walk fast and have my oxygen drop, or I could walk slow and my oxygen stays static. So I don't know which way I should go on that.
It depends on what is the intent of the test,
Excuse me?
right? It depends on the intent of the test. If you're looking for an apples to apples test, you should do the test from
The
your
same,
perspective the
both
same
ways.
way. If you're looking to qualify for some oxygen or change your prescription because you need that more with your workout, then you should probably change the way you do your test. From a provider's perspective, if I'm doing that for to assess for disease progression, I record all the parameters. There's lots of data points that comes out of a 6-minute walk test. So the starting oxygen saturation, the lowest oxygen saturation, the amount of oxygen that was required to recover the oxygen levels, the distance walked, the level of shortness of breath that was experienced, and the heart rate at the beginning and the end. So all of those things, if you slow down but your oxygen levels stay the same, I'm going to notice that if I'm paying attention, because you're not going to walk as far. And so I'm going to hopefully tell you, you know what, I noticed that your oxygen levels did a little better this go-round, but you didn't walk but half as far as you normally do. What'd you do there, buddy? And so, so hopefully we'll be noticing that and having that conversation if that's the intent.
If you drop, for example, say I drop down to 84, okay, with no oxygen, okay, and then I basically recoup, okay, sitting down in a minute, I'm back up to 93, okay? So how is that treated? You know, if you go up that far in a relatively very short period of time.
So I will give you a short answer, and then we can talk further. We'll be up here, I just want to say, for a few minutes anyhow. But the short answer to that, I think, is if you're trying to avoid getting oxygen by stopping your exercise short of what you can do, you're going to end up in that spiral where you don't do, so you can't do, and then you don't do, so you can't do. And so the point of adding that oxygen is so that you don't limit the exertion and that you don't lose ground from a conditioning standpoint. That's the short answer. If you want to talk longer about it, we certainly can. I have a couple.
Oh, hi. On the Etanks in storage, will it empty by itself just by being stored?
Yes, Jamie brought that.
So no, the compressed gaseous system, as long as it's closed, that oxygen will stay in there and it'll stay full. They do have expiration dates on them, and they need to be regularly changed if they're not being used. I would say the expiration date is not beyond 6 months. So if they come to check your home concentrator and they realize that there's some portable tanks there that have not been used yet, they should be switching them out at that time.
Yes, I have had my Inogen for quite a few years, and you said check these filters about once a month. I usually have it on the floor next to me when I'm watching TV, and I have to check those filters about every 2 days because it depends on how much dust you have. And also, it does not like humidity. And I've had it shut down with high humidity.
The oximeter, you're saying?
No, the unit would shut down.
Okay. So as far as your environment and cleaning your filters, I'm glad that you were aware and you were checking it. So your environment is going to play a big role in how often that you need to maintenance your filters. If you're in more of a dusty environment, then that would...
You mean those round ones inside?
I'm sorry?
Or are you talking about the filters out here?
The external filters that pop out.
Okay.
Those should be washed and dried with soap and water. Stay away from any hard chemicals. Soap and water and air dry. Dawn dish detergent will work fine.
No, I just do it and just clean water.
Yes, sir.
And faucet. Yeah.
Yep, they just pop out. There's 2 filters on the Inogens. They pop out. They're real small. Wash them, air dry them, and pop them back in.
I have to do that about every 2 days.
Well, thank you for your input.
Couple of questions. Our state manufactures liquid oxygen, so we still can get it, even though it is more expensive. But can you tell me the difference? Some of our people, when they travel, are only able to get, or the places only have industrial grade liquid versus medical grade liquid oxygen. Can you tell me the difference?
I wish I was more properly prepared to answer that question because our region, we don't do liquid oxygen. I don't have enough information on it. I would ask your local suppliers there.
Thank you.
You know, I just want to add to that.
Go ahead.
Oh, no, I was going to say that I'm aware of a patient or two who actually take their own reservoirs and
Right.
travel across state line.
But they need to be filled
industrial.
sometimes.
So I don't know the difference that you're asking, but I know that they're not going to a DME to get their liquid oxygen. They're going to an industrial supplier that they refill from. But anyway, I would find out more information. Yeah.
Okay, thank you. And one more question. When when you're sitting down and you're on 4 liters of oxygen and you need to have 8 liters of oxygen to walk to the bathroom, let's say, it's my feeling that you should turn that oxygen up before you get up and walk to the bathroom rather than play catch up when you get back. Is that correct?
That is in the perfect world, yes. But we understand it's difficult. Some patients have their concentrator upstairs, downstairs, and they are walking upstairs to turn it up. That can't be. So we're looking at technology for remote control. But yes, that's the ideal thing, is turn it up first so then you're not desaturating and then trying to catch up.
I just very quickly want to say my husband was a gadget man, and we had to have 2 oxygen concentrators. We purchased a 5, and then we had a 10. So when he was on 8 liters of oxygen and he needed more, he had them Y-connected. Mm-hmm. The 5-liter was plugged into a plug-in that he could turn on and off with his cell phone. And he had it on 2 or 3 liters, so he would turn it on, and it would give him the proper amount of oxygen. But that's rather complicated, but...
So he programmed this through his cell phone to do it remotely?
It was actually, one of those, I think they're called Wemo plugins, we did have 2 oxygen concentrators,
right,
so that was the difference. But not everybody has 2.
But he could remotely change the flow rate.
When he needed 8, or 10, he'd have 8 on the first one, and then on the second one he'd have 2, and then he would just turn that second one on with his cell phone. He was pretty innovative.
I just have a comment on travel with oxygen, and I have been able to arrange for delivery of the home-style oxygen concentrators to locations like this hotel through my service provider. It's covered by Medicare Advantage, and the monthly bill is no more. It's just like I was at home. So you should check with whoever your DME is. At the very least, they can arrange it with a local supplier, so you can have that type of equipment where you're staying, both commercial and home.
So yes, and I'll speak to that I can only speak for Apria, but our supply for traveling patients that are already on service with us, if you're going to somewhere that we service, which is pretty much everywhere, then we will meet you there with home concentrator and portable systems while you're there. We ask that you, for at least 2 weeks in advance, give us a heads up that will be happening. If you're not going somewhere that we service, or if you're traveling via airplane, we'll give you one of the portable concentrators that are both continuous and pulse dose that you should be able to use for home if we're not able to service you there. So we try to cover all of our bases. Not all portable and pulse dose portable concentrators meet the liter flow requirement of our patients, so that's something we have to look at. But if you were at a 2 liters per minute, the portable concentrator with pulse and continuous flow for travel patients is something that would adequately provide you services.
Yes, on that medical versus industrial compressed air, it's on the medical side, it's like you get to 90%, but on the industrial side, it does not deliver that level of oxygen.
Okay, thank you.
I have a question about the POC. I just, the little button that comes on and says to change your columns has recently come on. And so I was checking into how I got those replaced. And one of the men that is an IPF patient also has the same kind of a concentrator. And he said that Medicare takes care of changing out those columns. Is that, well, it might be a Medicare question. Is that a company possibility, or is it Medicare?
So Medicare is paying whatever, if you have Medicare and you're going through your insurance for your oxygen supplier, they're paying that oxygen supplier to service, provide, and all oxygen therapy related to you. They need to maintain, exchange, do whatever they need to do to make sure you're receiving the therapy. So in Apria's case, if your columns went out and your equipment was no longer working, we'd exchange it. We may, if we didn't have it in stock, we may exchange it for, say, a portable tank with a conserving device until we were able to replace or fix or exchange what we had given you originally and give it back to you, but it would be on our highest priority.
Okay, thank you.
I use oxygen with exertion, and I have the pulse regulator. And as I exert myself more, when I start, I can hear the puff when I start to inhale. As I exert myself, it seems like it gets out of phase. I'm hearing the puff when I exhale. Is that what's actually happening?
Yeah, so the sensitivity and technology is something that I'm sure is steadily advancing. When you get out of breath or exerting yourself more, you might be taking shorter, shallower breaths.
Yes.
It may not be enough to trigger the sensitivity level, so it could be getting out of sync. I'd probably work on breathing techniques. I'm not a clinician, but maybe when you get that shortness of breath, just make sure you're taking good deep breaths to trigger that oxygen.
It's easier said than done.
Yeah.
I would also remind you to check your saturations. I mean, if you're exerting yourself, this is exactly what we were describing, that shorter, shallow, more rapid breathing pattern, which is what you do when you exert yourself. So checking your saturation is really the only way to know if that oxygen is being delivered, because it could be out of sync. And we could test you, but you should really check yourself during that exercise. I don't know if you have any. Do you have any? Okay. Yeah.
And at that point, I probably then would just have to increase the flow to continuous flow on the.
You may need to switch to continuous flow with exertion. Yes, that's a possibility.
Thank you.
Got, I think, two questions. One, as you were going through the slides earlier, you mentioned a website that does a monthly newsletter, I guess, online, and also does an annual review, and we went through so fast I couldn't get it written down.
I believe you're going to have access to the slides. They'll be posted, is that correct? Yeah, on the PFF website. It may take a little bit to get them uploaded, and I agree we didn't have time to go through all, but those slides will be available to everybody. And yes, there were some, I actually skipped over that slide. There were some great resources on there including the foundation and other sites. But that'll be available for you, and you can check the website, over the next few weeks to see when they get posted.
I'd like to know with the portable oxygen concentrators, what is the most powerful brand or one that you have that you could recommend to patients who are on oxygen? One of the complaints we get quite a bit within our support group is the lack of ability to go up and also to go into the continuous flow part of it. That keeps coming up over and over again. Is there a POC that has that capability, a real powerful one?
And everyone can weigh in. The one I know of is the highest, and we're not branding anything here. We don't have any relationships with these companies, but the sequel is one that will go to 3 continuous flow, and there may be others. No POC that I'm aware of goes above 3 liters continuous flow, and I think you can weigh in. And then to pulse, I think this one goes either to 6 or 9. But this is 22 pounds in a stroller. And it's about, this tall. And I don't know do you know of other brands that go?
Yeah, the one thing I would add to that from the DME perspective is we can't carry 15 modes and models of POCs. So we select the one that we feel is going to provide to the majority. The one we carry is the Inogen. Pulse dose goes to a setting of 5. The reason being, one, to service the biggest population of patients as we can with a smaller SKU, if you will. And the reimbursement for portable oxygen concentrator is the same if it's a 5-pound one or a 20-pound one. So there's a lot of cost comparison there too. I would check with your local suppliers, call around, be your own advocate, ask for the best that you can get in your area and what different people have, and that's going to be best suitable to you. And one last thing I'll add is just because one POC goes to a setting of 6 and one goes to a setting of 4 or 5, that doesn't mean that the setting of 6 is delivering more oxygen than the setting of 5, because apples to apples are not there. When they say a setting, it's a number. So it's important to check your saturations, because one, maybe an Inogen setting of 2 will deliver the same as a sequel setting of 5. And I'm not saying that factually, I'm just saying you need to check your sats on the different equipment, find the one that works best for you individually.
I had one more question on airplane travel. Somewhere I was informed that most airplanes do not, although they're pressurized in the passenger section, it's not up to the same pressure as when you're at the ground as far as the oxygen level. Does that need to be taken into account or increase in the rate when you're on a jet airplane at whatever altitude?
Is the question about the cabin pressure at flight?
Yeah, can you just talk about what's the difference about being at that 8,000 feet pressure?
I mean, you want to talk about altitude?
Yeah, it's like a haystack. If you go higher, your density of oxygen goes lower, so you may require a little more. Yes, absolutely. But we do an altitude testing that Susan spoke about. It's kind of funny that in Tucson we don't have that testing, so I let all my patients go up to Mount Lemmon, which is 8,000 feet, and then they go check and see if that would work for them or not.
I am a respiratory therapist and also a leader of our support group. I think what I have a question about is about patients that require excessive amounts of oxygen with exertion. I've heard that people turn their oxygen up to 15 liters, 16 liters. However, they're using oxygen devices that don't support those types of flows. When you go into a hospital system, the oxygen that can be supported with a regular cannula is no more than 6 liters. So turning your oxygen up to an excessive amounts of flow doesn't benefit the patient, and I don't know if we in the medical world are not doing a good job at educating our patients to know that if you need excessive amounts of oxygen, that they need different devices that will support that and will give them the amount of oxygen they need versus turning their oxygen up on a regular nasal cannula and not being able to get the oxygen they need. So I think there's a lot of conversation about devices, meaning POCs and concentrators. There's very limited information about the difference between a regular nasal cannula. There is some information about high flows, but there's not, in general, a lot of information that actually educates our patients to know that if you turn your oxygen up to 15 liters, you're not getting that flow. You're not getting the oxygen you need because the device that you're using does not support that.
That is a good point, and we do, we do ask our DMEs, and Dillon can talk a little bit, for high flow cannulas. So up to 10 liters, our DMEs basically say they can provide up to 10 liters, and that may be also wind together, stationary concentrators that are high flow. But we can ask for a high flow cannula for the patient. And again, when they come into clinic and they're on an Etank, we can tell if we go from 5 to 6 to 10 by their sats that they are getting an increase in flow. But over 10, all bets are off. I agree with you. So we do talk to the DMEs about high flow cannulas, and I don't know.
Yeah, there's other options as well. And a great option too to rid the sensitivity of nosebleeds and things like that for high flow. Once you get to 6 and greater liters, you're eligible for a simple mask. The reason you can't use a mask when it's below is because of CO2 buildup. You have to have at least 6 liters to blow that CO2 out and ensure that all you're getting is pure oxygen. It's a great option for those high flow patients. And you're ensuring that everything that's caught in that mask, they're getting in. So it's a pretty good option, and it helps the nose sensitivity.
Just to respond to this lady's question over here about a machine. Respironics makes the Simply Go Mini, which is about 1 liter maximum. But the Simple Go weighs 10 pounds, and that goes up to 2 liters. And it has continuous flow, it has pulse, and it also has a sleep mode, which is very good at conserving air on long plane flights. The other thing about the plane flights, when we go to Europe, we try to fly on the Dreamliner, which is the 787. It pressurizes the 5,000 feet, not 8,000 feet. That makes a big difference for oxygen needs on a 6 or 7 hour flight.
Yeah, I just, and then maybe all of us have comments here, but I think the overarching theme here is that we do not have adequate technology for high continuous flow oxygen that's mobile. So that is a huge area of technology, of research, and everything we're hearing and seeing reflects that unmet need, as we would say. So I think when you're talking to your congressman and doing some advocacy, you know, this is a mobility, quality of life. We've even talked about, this came up in a conversation I was having last night with discrimination. You know, is this an unintentional population that's, you know, not being supported with mobility? You know, we would have a wheelchair person, we build a ramp for them to access and be able to go out. So in my mind, this is my just personal opinion, but everything we're talking about reflects a huge unmet need in technology. And it is underway. I mean, I don't know if you're in conversation, but I get calls from tech companies that are working on remote control, stronger batteries for POC, higher flow. So I think anything that any of you can do with an industry, advocacy, education, like you're mentioning, educating our patients and our clinicians. You know, we're in communities where we have nurses in clinics, and outlying community centers, there's no education. There is no nurse in the clinic. They don't maybe have even a medical assistant. So I think all of you who have been here can take away, you know, the Pulmonary Fibrosis Foundation Oxygen booklet. If all you did was send your referring offices or the MA, you know, the foundation, here's their site. Give this to your patient. If they just handed it to the patient, it would help. So there's a lot of unmet need that the foundation is very involved in. We're all trying to get that out there. But like you mentioned for high flow, you know, trying to Y together and thinking you're getting 16 liters, it's very challenging. So I would just say anything any of you can do to help get resources and advocacy for mobility and high flow, it's a huge need. So because all of these questions reflect, and travel.
On my engine here, there's canisters on the side there. How often should they be replaced?
So it should have an alarm that'll tell you when the columns go out. It's kind of hard to tell until it gives you an alarm that they're no longer properly working. So I don't think it's a routine maintenance schedule on those. They have a life expectancy. It'll alarm when they're gone, and then it should be exchanged.
Well, sometimes it shows error, you know, oxygen error or whatever. And I'm just wondering if that's those canisters on the side.
Yeah, I could
shut it off.
We can
turn it back on, and it flows okay.
We can catch up afterwards if you have more specific questions about that, if you'd like.
Okay.
I just wanted to, people who have POCs and the longevity of the battery, when Bob and I travel, he has a thing that plugs into the cigarette lighter, and he keeps it plugged in. And recently we were on vacation, and a taxi was taking us to a place he wanted to go, and we said, hey, can he plug it in? And when we got to our destination, his thing was at 100%. So, you know, there are things like that if you're traveling around in your own car, even when we travel locally to
Just
go
plug it in,
shopping.
yeah.
We
And
take it and plug it in.
And I would say plug it in when you're waiting for your flight. I must say
we
I had
do
one
that too.
experience. Yeah, I had one experience. I was plugged in for my computer, and the plane I was on, I said, you know, it's not working. Well, they would turn the electricity on at the front of the plane for a while, and then the middle, and then the back. So all of a sudden, and I was thinking, if I was a patient planning on, because when I called, they said, oh yeah, we have plugs, but it intermittently went on and off. So that was, but anyway, good point.
So that was my question. If you have a POC that you can plug in, can you plug it in the airline
Yes,
You
but,
can.
but the airline letter will typically ask that you have 1.5 the hours of your flight in battery life. So you have to say, if you have a 4-hour flight, that's 6 hours of battery. That's a lot of batteries to haul around, right? But yes, you can call ahead, but be sure you say, is it on, the whole flight, the whole way, but you can plug in.
Thanks.
We always say plug and go. Keep it plugged in until you can't have it plugged in.
One last question.
Have a support group in Canada, and we have people, like everybody here, they all travel. And when you're not traveling, you've got all these extra batteries. And they have what they call the battery pool now. And they loan each other's batteries so that you're not buying 6 and 7 batteries. And it works fabulously. And just, it's expensive to get those batteries, but it works great.
Awesome.
Thank you. One last? Anyone else?
I will be here for a little bit.
Yeah. Well, thank you all for coming, and thank you, PFF, for arranging this. And thank you, Susan and Dillon.
Thank you.
Yeah.
Thank you.